And talking about what we happen in Puerto Rico right now regarding to people aging with HIV. As we mentioned several times during the day, people with HIV is aging and Puerto Rico is not a different. In 2022, 63% of people living with HIV are 15 years or older and older. But we have a bigger crisis right now because talking about people who is aging, we have more than 1 million people who live in Puerto Rico who have 60 years or more, and we only have 83 geriatricians in the whole island. When I live in one of our practice, we only have 1 geriatrician, and we have more than 200,000 people living in that area which are over 60 years old. USA have the same situation. They have more demand than the supply, and that problem is going to increase through the years, and that's why we look forward to how the primary care providers can engage to give real good geriatric care to our patients living with HIV specifically, and we focus to expand this also to people who is not living with HIV. Centro Ararat is a non-profit private organization who have been working on the HIV field for more than 24 years. We have 3 primary care locations, and in our database, we have 1,100 patients with HIV. Of that, more than 600 are 50 years or older. In Ponce, we have 250 patients with HIV who are 200 who have 50 years or older, and from those, we create a cohort that is called Premier Platinum Program with 72 patients who accept to participate on that. In that specific cohort, we have 3 components. First, we create a dedicated geriatric healthcare team workers. What we do, we train people to work with geriatric patients. The first thing, we add a physician assistant to our team. Physician assistant maybe is very common in the US, in mainland USA, but not in Puerto Rico. It's less than 7 years that we start accept physician assistant to work. I've been blessed to have our physician assistant here with us, and she was trained by a geriatrician for 3 months to learn all the things that we had to do, all the tests that had to be done to our HIV patient to detect everything that we need to cover. Then we do a specialized geriatric clinic using the 5M, and through that 5M, we add a specific geriatric psychological part to try to look around and help all the psychological well-being that is needed of people aging with HIV. Last but not least, we add a patient education and empowerment program because we can do something with our patient. So we need for them to be integrated. This is the landmark of what we do. There are six different parts. Here are some of the different screening that we do, but right now we're going to focus specifically in the mind area. The implementation of the mental part of our 72 patients have the MOCA test. Why the MOCA test? Because it's really easy to do. You don't need to be a psychologist to do a MOCA test. In Puerto Rico, everybody thinks that you have to be a psychologist or a geriatrician to do a MOCA test, and you don't have. You just have to have a certification to do your MOCA test. And also, it's one of the best detecting the executive dysfunction that we are looking in our patients. Of those 72 patients who are 50 years of old, our cohort of Premier Platinum Program, most of them are male. We divide because we are looking at the beginning when we start this in 2023. It's like, okay, what happens? It's not the same when we have someone who is 50 years old than we have someone who's 75 years old. So we divide our cohort internally at those who are more than 65 years old and less than 55, and also half. But you have to look that there's more female in the area that are 65 years older or more. The education level goes to the lower school up to doctorate degree. The age of HIV diagnosed from 20 years up to 75 years when they got been diagnosed with HIV. Living year from 4 years to 37, and the range of the MOCA test go from 15 to 29. And that really identified the reality of all the HIV population, not only in Puerto Rico, I will say in the whole USA. What have we found on the full cohort correlation regarding the MOCA test and the result? There's a strong positive correlation between the higher education, a high MOCA test. There's a female sex associated with lower MOCA test, even when we adjust regarding to education and other variable. There is a longer duration of HIV infection linked to a lower MOCA test, and the older age of HIV diagnosis is associated with lower MOCA test. So we decided to do a subgroup called a cognitive group. What we got, after doing a lot of literature review, we decided to use a cutoff of less than 24 in the MOCA test as being a predictable of patients who have some kind of neurocognitive impairment. Sorry, along to that, we look about those who have high scholarity less than high school or less, those who have been living for more than 20 years with HIV, those who have been diagnosed of HIV before the 2000 or the 2YK, and those who have been their HIV diagnosed at age 50 or older. And we predict maybe how many of them will going to have a neurocognitive disorder, neurocognitive impairment, sorry. All of them have been referred to a neuropsychologist. We only have 4 neuropsychologists in our island. So we have blessed to find someone who assessed our patient, and from those 40 patients that we refer to them, only 33 of them get to the neuropsychology and get their evaluation. The mean age of that group, 67. The highest MOCA test is go up to 23. The average amount of years with HIV is 22 years, and no one from doctorate degree get in that area that have a MOCA test less than 24. So what the neuropsychology found and diagnosed in this subcohort that we call a cognitive cohort, he diagnosed 8 patients with major neurocognitive disorder, 2 of them related to vascular disease, 5 of them related to HIV disease, 20 with mild neurocognitive disorder, 4 of them related to HIV, 4 related to vascular disease. And of course, there's a group of patients that doesn't have a specific diagnosis, and it's called other cognitive disorder. And you can see that the ICD-10 that is R4184 is those who have an abnormal MOCA test that means less than 24, but there's no clinical finding in the patient except for some attention or concentration deficit. It could be a multifactorial, the reason why the patient could have that less than 24. When we compare the prediction that we do on the diagnosis by the neuropsychology, we found that specifically those who the age of HIV diagnosed was at 50 years old or older, we have a specific correlation that is significant, that it will have a higher probability to have a neuropsychological neurocognitive impairment, and also those who have a high school education or less. We use that right now. We have more than 500 patients that we need to prioritize to find to whom prioritize to do the MOCA test and send to the few neuropsychologists that we have, and we are creating a risk score to working with this patient so we can select and prioritize with those who really need it earlier. Also, we found a good correlation that lower MOCA tests, those who have 15 through 19, have a major neurocognitive disorder diagnosed, and those with highest score that is up to 23 of the cutoff that we use, or less than 24, that have a mild neurocognitive disorder. As a conclusion, we can mention that from the universe of patients that we have of 1,100 patients, we found right now 32 of them that really has a specific need based on diagnosed neurocognitive impairment. And that's mean demonstrating that this kind of initiative that I mentioned, this is just part of the 6 different parts that those initiatives have that we started in 2023, demonstrate that in the absence of geriatric care, primary care provider can be trained to do that kind of job. And I know someone mentioned before that they have been blessed having a geriatric physician in their clinic that do all this elimination of medication, do all the tests. That's right. But we are not blessed to have so many geriatricians in the clinic, and we know our patients need that kind of care. I want to end saying that if we start doing evaluation of mental cognitive situation alone, with psychological evaluation inside of the primary care. We put all together in all those things that the patient I used to do as the primary care. We were going to have a timely diagnosis. We were going to have a timely intervention, and that will end having older adults living with HIV, but with autonomy and dignity. I just want to recognize all the people that made this project possible. We have been an implementation team, an intervention team, of course, our institution, one of the grants that we received for HRSA to help in part of this specific job, and our patients, of course, who are the main reason why we do that. And we learned through this project one thing. It's the first time that we use patient liaison in our clinic, and now it's a essential step in everything that our institution is going to do. They always ask the patient, what do you think about that? We need to improve, and we include them in everything that we work at the clinics. There's the reference that we use, and I know it's really hard to hear how many challenges our HIV aging population have, how many of them, how much is this population growing, but we have to be honest. We have to learn that we have to start to plant trees in areas when we know that we are not to enjoy the shade. So maybe I start this work, and we all here start this work here today. Someone is going to continue, but the most important part is the seed is already planted. Okay? Have a good afternoon.